Welcome to This Explainer. Today, we're diving straight into a deeply complex and, honestly, historically misunderstood condition that affects millions of people all over the world. We are demystifying endometriosis. For the longest time, this condition was essentially brushed off in the medical community as just a localized, purely reproductive issue. But, as we're going to see from the latest research, that couldn't be further from the truth. Let's get right into the data and see what's really going on.
Let's start right here with a truly staggering number, 10%. That means roughly 10% of all reproductive-aged individuals with a uterus suffer from this condition. To put that into perspective, this is an absolute epidemic walking quietly among us. It's affecting our friends, our family, and our colleagues, and very often they're suffering completely in silence.
And the stakes here? They're massive. Not just for the individual patient, but for society as a whole. Take a look at the United States alone. The estimated yearly direct medical costs per patient sit at $12,118. And the indirect costs, things like lost wages and a drop in productivity, those hit $15,737. So right out of the gate, we're looking at an immense personal and economic burden that we simply can't ignore. So we need to completely scrap the outdated, pretty dismissive myth that this is just a bad period. It's not. Endometriosis is an estrogen-dependent, chronic inflammatory condition. It's characterized by endometrium-like tissue functioning right outside the uterus. The key takeaway here is that we are firmly anchoring this as a systemic, inflammatory disorder. Here's a quick roadmap for our explainer today. 1. A widespread hidden epidemic. 2. The biology of endometriosis. 3. The science of chronic pain. 4. Modern diagnostic tools. And 5. Medical management strategies. All right, let's jump into part 1. A widespread hidden epidemic. So who is actually most affected by this disease? The impact is heavily concentrated in specific groups. It's disproportionately found in patients dealing with chronic pelvic pain. In fact, it accounts for 60% of those cases. It's present in a massive 80% of patients who have dysmenorrhea, or severe, painful periods. And, perhaps most devastatingly, it's found in up to 50% of patients dealing with infertility. Interestingly enough, there's also a genetic link. If you have a first-degree relative who is affected, your likelihood of having the disease yourself jumps to 7%. Moving right along to part 2, the biology of endometriosis. What's actually happening at the cellular level? Well, these ectopic endometrial lesions actively release inflammatory mediators, like cytokines and prostaglandins. Think of these like tiny fire alarms going off in the body. These lesions aren't just dead, inactive lumps of tissue. They are highly biologically active. They actually have increased aromatase activity, which is an enzyme that creates estrogen, leading to localized estrogen spikes that drive even more tissue growth. And to make matters worse, this whole inflammatory environment impairs the function of peritoneal macrophages and natural killer cells. In short, the lesions create a little local environment that ensures their own survival, evades the immune system, and pumps out chronic inflammation. You might be wondering, how does this tissue even end up there in the first place? Well, the truth is, there isn't just one single answer. We have Sampson's theory of retrograde menstruation, where menstrual effluent flows backward into the pelvic cavity. But we also have theories about endometrial stem cell recruitment, developmental anomalies like Mullerian rest induction during fetal growth, genetic and epigenetic changes, and even microbiome alterations that promote chronic inflammation. The crucial point here is that the disease likely isn't caused by just one of these things. It's almost certainly a highly complex combination of these integrated models. To add another layer to that complexity, the disease actually shows up in 3 distinct forms or phenotypes. We have superficial peritoneal endometriosis, ovarian endometriomas, and deep endometriosis, which is defined as invading tissue deeper than 5 millimeters. Right now, doctors are literally still debating this. Are these 3 distinct phenotypes developing through completely separate mechanisms, or are they just a continuous, progressive spectrum of the exact same disease? The evidence hasn't definitively proven that one morphs into the next, which really just deepens the medical mystery. Okay, part 3, the science of chronic pain. This brings us to probably the most common and devastating frustration for patients. Why on earth does endometriosis cause such varied, widespread pain that sometimes doesn't even feel related to the pelvis? To answer that, you have to think of it like crossed wires in the body's electrical system. The lesions kick off an inflammatory response that sensitizes the adjacent nerves.
This leads to what medical professionals call viscero-viscero and viscerosomatic sensitization. What this means in plain English is that a stimulus from a highly inflamed internal organ, let's say the uterus or the bowel, triggers a reflex. That reflex causes pain in a totally different organ, or it refers the pain outward to the musculoskeletal system, so the abdominal wall, the muscles, or even the skin. This peripheral and central sensitization explains exactly why the pain perception is so widespread and severe.
And this cross-wiring, it builds into a much broader, much tougher patient experience. Endometriosis frequently overlaps with other chronic conditions. We often see chronic pelvic pain syndromes like irritable bowel syndrome and interstitial cystitis grouped right alongside it. We also see extrapelvic comorbid conditions, things like fibromyalgia, migraines, and chronic fatigue syndrome. This scientifically validates something absolutely crucial. Endometriosis is not an isolated reproductive issue. It's a systemic disorder that profoundly affects the central nervous system.
Section 4. Modern diagnostic tools.
So how do we actually find it? Doctors follow a few structured steps. It starts with a comprehensive clinical history and a pelvic exam to identify tender points. Step 2 relies on advanced pelvic ultrasonography. Now, what's really fascinating here is a specific maneuver called the uterine sliding sign. By applying pressure with a transvaginal probe, a doctor can see if the anterior rectum easily slides across the adjacent vagina. That simple maneuver helps detect deep endometriosis and adhesions in just about 5 extra minutes. Step 3 brings in MRI for more ambiguous cases or deep disease. And finally, Step 4 is still the gold standard: surgical staging to definitively visualize and classify the disease. Now, I know what you're thinking. Why can't we just draw some blood and be done with it? Well, there's a huge hurdle called the biomarker challenge. For any blood or saliva test to actually replace surgery as the gold standard, it has to hit greater than 94% sensitivity and 79% specificity. While it's being heavily researched, impartially speaking, no current test on the market reliably meets those incredibly strict clinical criteria just yet, so validation is still a massive hurdle for researchers. Which brings us to our final section, Part 5, Medical Management Strategies. When it comes to first-line treatments, we're usually looking at combined hormonal contraceptives and progestins. The mechanism of action here is pretty straightforward: cause ovarian suppression and force those ectopic lesions to atrophy. While these are often highly tolerable and super accessible, we do have to acknowledge the reality of the data. Up to 30% of patients report absolutely no improvement in their pelvic pain when using combined hormonal contraceptives. If those first-line options fail, doctors might step it up to advanced treatments like GnRH agonists or antagonists and aromatase inhibitors. These medications aggressively block estrogen production to literally starve the lesions. But because they create a hypoestrogenic state in the body, they require strict clinical monitoring for side effects. The most notable one to watch out for is the loss of bone density over time. And of course, we have to talk about surgery. For a lot of people, when medical management fails to relieve those stubborn symptoms, or if a patient can't take hormonal medications because they're actively trying to conceive, surgery isn't just a diagnostic tool. It remains a vital cornerstone of endometriosis care and symptom relief. As we wrap up this explainer, I really want this quote from the source material to sink in. Endometriosis functions as a systemic disease affecting non-reproductive systems. That's the real game changer here. The medical community and society at large absolutely must stop viewing this strictly as a localized uterine issue. We have to start treating it as the complex, systemic, chronic inflammatory disease it actually is. And that leaves us with a pretty big, provocative thought. As science continues to unlock the deep genetic and microbiome secrets of this disease, how will the inevitable shift toward personalized, interdisciplinary medicine finally change the narrative for that 10%? It's a future of care that millions of people are desperately waiting for. Thank you for joining me for this explainer, and keep learning.